Hi, everyone. Thanks for joining us this afternoon for an OpenNotes webinar on improving the quality of OpenNotes implementations. So today we're going to spend some time talking about improving portal navigation, making notes easy to find on the portal, and communication strategies related to opening notes. So what kinds of things do patients want or need to hear about opening the notes? Then we're going to revisit a perennial topic, which is culture change. So you'll hear throughout the presentation that the technical requirements for OpenNotes are the easiest piece to fix, and it's really the culture change that causes more of a barrier. And then finally, we'll get to the question and answers. So we should have plenty of time for that. A couple of housekeeping items just to start off, as Amanda mentioned. Amanda, could you advance the slide? So if a question comes up during someone's presentation, just put it right into the chat box, and we'll be monitoring that, and we'll make sure that we address any of those submitted questions at the end of the prepared comments. And then, so that way, if you think of something, you don't have to try to remember it, but just send us a message right away. If something comes up during the discussion period, you can use the raise hand. So here's a little screenshot of what that looks like. You can see the little hand there. And we will unmute you. Amanda will unmute you, and you can ask your question. So just to set the stage, I'm going to spend about 2 minutes just talking about where we are with OpenNotes now. So as of now, we have information about 450 health systems in the U.S., a few, and then a couple in Canada. We have confirmed 184 launched. Those are confirmed by us. And then we have another 31 where we know an organization has implemented, but we haven't been able to document it yet. There's another almost 40 organizations that are either launching soon or piloting, and then another close to 100 that are either committed to doing OpenNotes, and we don't necessarily have a timeline yet, or they're interested in doing it. And then another 100 that are aware. So that's a pretty steep growth curve over the last couple of years. And what this all means is we now know of more than 33 million patients that have access to notes. We have so these are patients who receive care at an organization that shares notes, and they are signed up on that organization's portal. We finally have implementers in all 50 states. And you can see on that slide that there are some places where we have quite a few, like there's California and the West Coast where we have quite a few implementers, and then we range from between 1 and 10 across the other states. So what we have learned through these implementations and following what's been happening is that it's just turning OpenNotes on is the first important step, but it's really not sufficient. Our evidence that we've been gathering, both anecdotal and then we now have qualitative and quantitative evidence that suggests that patients either are not aware of or of the fact that they can read their notes, or that their clinician even writes notes, or they can't find them. We continue to see that anxiety around transparency is a major obstacle on the health system side. So today, we're going to be talking about both of those things. Both how do you make it easier for your patients to know about their notes and how to find them, and how do you tackle this anxiety on the provider side. So we're going to start. I'm going to turn the panel over to our first set of presenters, and they are going to talk both from a kind of clinician, health system perspective, and a patient perspective. We're going to start with John Santa, who is our Director of Dissemination.
Hey, thanks, Kate. And thanks to all of you for coming today. It's really terrific to see the interest in OpenNotes, and as Kate has, I think, made a bit of a case for, we think we're getting to the tipping point where implementing OpenNotes is becoming the thing to do, and we're thrilled by that. But we're also challenged by the topic we're going to talk about today. Next slide. I like to start all of my conversations now by putting the folks who are most important first, and that's patients and families. And in many cases, I think this is a clear-cut decision for organizations. Do we put what patients want and need first, or do we slow things down because of the anxiety of our clinicians? And so we're really talking about those two things today. Next slide. I love this slide. It's from wonderful Liz Salmi, and with her permission, we can see an after-visit summary on the left and a note. And what more can you say about the difference between the two? For the person who wants to know, as Liz says in such a lovely way, I'm a curious person, and I want to know about what's going on with me and my health and my life. It's a pretty stark comparison in terms of the information between an after-visit summary and a note. Next slide. So we began to think about should we look deeper at what's going on a couple of years ago. We did so because we were interested in confirming the research findings that in the sites where the research was done had pretty high note opening rates. We also began, as we traveled around the country and ran into patients, and sometimes doctors, sometimes health policy folks, who we knew were at organizations that shared notes. We would ask them if they had looked at their notes, and they would look at us in a puzzled way and say, no one told me I could see notes. And sometimes we would even be able to take them to a terminal and show them their notes. Because some of them would say, yes, I've heard about that, but I have no idea how to find my notes. And now, quite honestly, we've had to be a little bit more sensitive to a word or two words we use frequently, which is non-event. Many of our implementations have been described as, this was a non-event. Not much happened here. Well, sad to say, in some cases, it may be a non-event because not much is happening. Patients aren't aware that they can see their notes, or they can't find their notes. Now, I want to assure you that we know of many, many robust implementations where we know that tens of thousands of patients are seeing their notes, and those organizations can feel the benefits. Ultimately, for OpenNotes to lead to what we think is its best outcomes, we need to take steps to maximize the benefits and minimize the risk. Next slide. So we began to look at qualitative data that we had from, Kate mentioned earlier, that we asked organizations to document their implementation, and we asked a variety of questions. So we began to look at that data and ask ourselves, could we predict which implementations were most likely to be effective? And when they also provided us with portal registration rates or a small sample of note opening rates, we could see, gosh, some of the implementations we thought would be quite effective weren't. And some of the chief medical information officers and others started to share with us what's going on here. So the first thing we did is we focused on communication efforts and began to try and get a sense of who was doing a lot of communication and who was not doing much at all. And we could see that only seemed to have a modest impact. Well, then we went back to several organizations, and 80-some organizations, and asked them specifically, would you share a note opening rate with us as defined in the slide there. So we're focusing on notes that are in the portal and what percent of those notes are being opened. And so ethic organizations, as you can see on this slide, were able to measure that, though only a minority were. Many ethic organizations responded that, that's not something we measure. It's not on our dashboard now. We really can't provide that data to you. But eventually we were able to collect information from 26 organizations. And frankly, we were pretty stunned by the results. As you can see, results fell in 3 tiers. We had 4 organizations, 2 of which were homegrown systems, who were in the best performing tier, with notes being opened between 21 and 34%. We had a middle tier in which notes were being opened by 6 to 10% of notes. And then we had a bottom tier, and it got quite low, as you can see, where really only a tiny fraction of patients were opening those notes. We set about trying to sort this issue out. We've just released a white paper called Implementing OpenNotes, Improving Access to Notes on Patient Portals. It's up on our website. All of you as attendees or registrants have gotten an email or should have gotten an email with a link. So we would urge you to take a look at that. Our hope is that this starts an important conversation about how to get to effective implementation. Next slide. Now, some of this is a vendor issue. We have a very good relationship with Cerner, and Cerner does a wonderful job of supporting OpenNotes. But in terms of measurements are more driven by their customers and Google Analytics, and Cerner folks were not able to generate a note opening rate for us. Could you go back, Amanda? Move back. Yeah, thank you. In talking to them, though, from the data that they were able to generate, we could see there were some very significant differences. In some Cerner organizations, a few thousand folks a month would be downloading notes. In others, tens of thousands were downloading or viewing notes. And when we talked to Cerner patients on Cerner systems, some of them reported, my gosh, I go into the portal and I click on a box that says Open Notes and I can see my notes, while others describe pretty tortuous navigation routes to their notes. In terms of Allscripts and Meditech, notes there are put in a file along with a number of other documents, and so right now they're impossible to measure separately. So we weren't able to get measurements from any Allscripts or Meditech customers. Epic has worked with us very productively. And as they begin to see this data, they've launched multiple near and now long-term changes to optimize note opening rates, and I think we're beginning to see some of those results. They've also standardized the note opening rate and included this metric in their recent versions. So many Epic customers can now see this metric on their dashboard and don't have to do any additional work to see this. We've appreciated how Epic has worked along with us in terms of these issues. Next slide. We think that ease of navigation is a very significant, if not crucial, factor. Not surprisingly, fewer clicks probably translate into higher note opening rates. We also think communication efforts are crucial, but so far they've been modest impact. Reminders we think are especially powerful, but we're also getting the sense that the details may matter in terms of how those reminders are structured, delivered, etc. And we're also now getting reports from some sites who have made phone access available, mobile phone access, and that looks like a significant number of folks will come in and look at their notes via their phones that perhaps didn't on their desktops. Next slide. So now I want to move to the next section of this implementing effectiveness and introduce two speakers. Naomi Kaufman Price has been involved with OpenNotes as a patient and then as an advisor in the Northwest OpenNotes Consortium since 2014. And she's going to provide her perspective. Following Naomi, Marcia Sparling from the Vancouver Clinic in Vancouver, Washington, will provide her perspectives on the work they've done tracking note opening rates and the multiple improvements they've made. Again, Marcia has been involved in the Northwest OpenNotes Consortium since its beginning in 2014. So I want to thank both of them and turn this over to Naomi.
Amanda, could I get the first slide, please? Thank you. This started for me when I went to a doctor and my after visit summary, the summary on top said, "Thank you for coming in today." So this is a slight paraphrase. "Thank you for coming in today. If you have any questions, feel free to call." It didn't give me any information on why I had been there, what we talked about, or whether there was any follow-up plan. So I thought there was a lot of boilerplate about getting a flu shot and I don't know, probably Ebola at that time, and a medication list, et cetera, et cetera. But there was really nothing about why I was there. So almost concurrent with that, Kaiser started looking into OpenNotes, and I was on Patient Family Advisory Council at that point at Kaiser Northwest, and the notion of OpenNotes came up, and we all just jumped on this. All of the people, I think, on that council thought this would be a great tool. They invited me to attend a meeting of the clinician leaders, and I did so. A number of other people spoke in favor of OpenNotes, and Kaiser adopted in, I believe that was 2014. I am no longer at Kaiser, but the rest of this is pretty much what people will see on almost any Epic system. Kaiser has done a little more customizing, and I'll talk about that in a second. If you go on to any MyChart, you will, after you've gotten a note saying a summary of your recent visit is available, most do not say your visit note is now available. So you log in. There are a number of tabs at the top, mailbox visits, medical records, and you have to, oh dear, that's my home phone ringing. Sorry, in the background. You have to figure out what it is you want. Do you want visits or do you want medical record? So you just experiment and you go to the visit tab at the top, then says the email says select either past appointment or or the prompt says past appointment or past admission summaries. Now, intuitively, I would have gone to medical record, and I know a lot of people do that, including just yesterday when I was talking to another patient. Then you click on the recent visit, you find the tab, and it then defaults to the after visit summary, not to the notes. You must then click on notes, which to most of us just means an addendum rather than something significant. So the takeaway from many patients, even people who have called up their summaries, I've discovered in talking with people, are that notes are an afterthought, not something necessary. So could I have the next slide, please? On the other hand, some really cool things are happening in OpenNotes. This just popped up recently on my prompt, and it said, and it allows me to connect notes with another health system I've visited. So this is a real advance for OpenNotes here in Portland, and it speaks to a companion issue, which is interoperability, which is so important as we, great many people don't just see one doctor in one healthcare setting. Okay, next slide, please. All right. When we do go to our notes as patients, we see all kinds of things. And I know that John, I believe, is going to talk a little bit about this later. We have language that can both confuse us if we don't know the difference between aphasia and apraxia and apathy or something. I don't know. That's off the top of my head. But we also see language that can really turn us off. I have multiple sclerosis. The first disease-modifying treatment I was on was Avonex, an injectable, and I have seen notes that say I failed Avonex. Actually, it made me really sick. And then there was recently a Twitter discussion on language in notes, and I really love the first one. I won't read all of these to you, but the note from an oncologist said salvage mastectomy or chemotherapy, and the patient told the doctor she was not a shipwreck. So when you use language in notes, it really, please try to remember that this is a partnership, and this is going to be really ongoing as OpenNotes develops and adoption read rates increase. Next slide, please. This is just self-explanatory. The first one deals with an actual error, or not an error, excuse me. Again, language denies ever smoking, and which implies that this person was lying about cigarette use. Now it says never a smoker. I had to go round and round with my provider on trying to get my notes fixed because my history said that I had never smoked. Well, in fact, I did, and that's something that did super past tense, but nonetheless, that needs to be in my notes. One challenge is getting your notes changed. We should think also about weight. Not every woman I know, when they see the word obese, much let alone morbidly obese or even overweight, they just shut down. It is probably sufficient to note someone's weight and, if you want to, BMI, and it's not going to be any news to them. Also, in terms of language, using diagnoses as labels. I have diabetes versus she's a diabetic. So, she has diabetes versus she is a diabetic. This I don't have diabetes, thank goodness, or epilepsy, but I don't want my diseases or diagnoses to define who I am. Okay, next slide, please. This slide will be on the record from this. This is from a journal called Diabetes Care from October 2017. It's a wonderful article on the use of language in diabetes care and education, and it has a great chart on common terms, alternatives, and why. Next chart. Next slide, please, Amanda. And then in looking towards the future, I really hope that in addition to clearing up two things on the portal. Number one, I would really like for the prompts to automatically default to the Notes tab, not to the After Visit summary. Part two is that I would like providers to make it clear on visits that you will be getting an email with the prompt to the visit note. I had a really interesting discussion yesterday with a woman who's been treated for breast cancer, and she had no idea she could access her visit notes. She did right then and there on her phone, and I could barely have a conversation with her after that because she was absolutely transfixed, and was so grateful to see that. And so in the future, we really do need to have some clarity on what an ability to jump directly to the notes. We also need, if people are just going to that home page, to clarify visits versus medical record. You cannot get your visit notes under your medical record unless you download your whole record. That's not what people generally want to do. Looking forward to what might be coming next for all of us, I thought this was really fascinating. Dr. Aaron Gray in Missouri on Twitter predicted that we are going to have recording clinic visits with an Alexa or Google or Apple Home type of device will revolutionize data coming out of visit. So doctors won't have to spend time documenting. It's already being recorded. And patients could play, this would be simultaneously into the record with patient access. And I can't tell you how important this is following anything where you're supposed to, a visit where you're supposed to do follow-up that is more involved with making a simple phone call. And I can really see the day when these voice-activated devices will be a tool for OpenNotes. And I believe that's my last slide. Thank you.
Thank you, Naomi. Marcia, I'm going to hand it over to you.
Thank you for inviting us to talk about what we've done here. We're big fans of OpenNotes, and we're happy to join you at this webinar and talk about what we've done. Just next slide, please. So as a little bit of background, we're an ambulatory organization in Vancouver, Washington, so we're not in Canada. And we are ambulatory, and we have an ambulatory surgery center, but we're not a hospital facility. We have about 250 provider FTEs, 5 clinic locations. You can see that we have a high portal uptake. 69% of our patients' visits are with patients who have an active portal. And we're not, although we're near Portland, I don't really think of us demographically as being part of the Silicon Forest. So we see this rate as being something that people could achieve in most communities. We don't have a particularly techie demographic, but we still have a high uptake of MyChart. The majority of our patients access through the web portal, and only 17% use the mobile app. We're working on promoting the mobile app because we think that probably is an awareness issue, but that's part of our setup. Next slide, please. So we started on OpenNotes in 2014, and I want to talk a little bit about the change management as we approach this, because I think this is one of the things that is a barrier to implementation in organizations. We brought the concept to our leadership team of managers and department chairs, and at least several people in the room were pretty worried about this idea and what it would mean and whether it would create a lot of extra work and confusion and more questions. So we said, okay, we'll go pilot this. And we piloted it with 4 providers for 3 months, automatically released their notes, and came back and said, you know, it was fine. We had 1 patient correction requested, and it was appropriate. It was a mistake. It's been fine. And tried to use the same dialogue, like what is the right thing to do for the patient. And we fortunately had one of our department chairs say, you know, when my wife and I got complicated medical care, we wanted copies of our chart notes to read so that we could process all that information. If I need it, I'm sure my patients need it too. I think we should go for this. And so we did. We started in July of 2014, and across the organization, default notes to release, except for the ambulatory surgery center and mental health initially. And in August of 2016, we did our EPIC upgrade and found that our note reading rate dropped from 19% to 11%, which we thought was due to their redesign of MyChart, because that seemed to be the only real thing that we could find. Our current note opening rate is sitting somewhere between 22 and 26%, depending on which month you look at. Next slide, please. So when we thought about how to make this more visible to patients, we tried to think strategically, like, what can we do to help patients find these notes? When would they want to read them? When they look at a screen, what do they see? Why are they missing these prompts? Do they know that they're there? How do we walk patients through and point them to their notes? So I think we've had a pretty good response to this, and that's really some of what we want to show you, is how we've customized this so that the patient-facing material is helpful. Next slide, please. So our note opening rate, one of the interesting observations when we were preparing for this seminar is, as we trend things, we see that people continue to read their notes even a month or two after their notes are released. And I think that that's really a tribute to the analyst's design of pointing patients to their notes. So they may log in and looking for a lab result or planning to request a refill, but they see a link that says, read your chart note, and hit on the link, and it walks them through and points them to the chart note. So I thought this was a really interesting piece of information. When we went live, we thought, well, we'll send them a tickler, they'll log in the next day or so and read that note, and that's not, people are reading notes at other times as well. So I thought that was worth pointing out. And another thing I want to mention about our note reading rates, when we did this analysis and we looked at individual provider note reading rates, they vary pretty impressively, and some of our providers have note reading rates in the high 60s. Those are typically our obstetrical and gynecology patients, and that department has really encouraged adoption of this. But we also have high reading rates in departments like orthopedics, where I'm pretty confident the orthopedic surgeons are not teaching people about how to use OpenNotes, but their read rates are in the high 40%. So I think there's a lot that's possible to do with this. So let's show you what this looks like, and I'm going to ask Stephanie, who's helped to build some of these tools, to talk about what she's done.
The first thing we asked ourselves is, where do patients know that they have a clinical note to look at? So we thought, well, we need a trigger to tell them to log into your MyChart and look at your after-visit summary, look at your clinical note. So we used the ability that after a patient sees a provider, for the system to automatically generate a message, which also generates a generic email. So a patient gets a generic email, log into your MyChart, and after they log in, they can see their message, and their message is very specific with instructions on where to go, and if they're not quite sure where to go, we have a nice little hyperlink in there to direct them exactly what page they need to go to.
Next slide. Can we have the next slide? Yeah, perfect.
So then we thought, okay, well, other than the message, where will patients expect to see prompts? You know, if they forget to look at their message, where else can we trigger them to make sure that they look at their clinical note? So on the home page, under the News for You, we have a paragraph on what OpenNotes is and a hyperlink, again, to direct them to that past appointment page. And we also have a quick link, as EPIC calls it, which is just a fancier hyperlink with a really pretty icon that also directs them.
It looks like a button on the sidebar, yeah.
Yep. And then once they actually find their way to that exact appointment on the past appointment page, there's verbiage on the after visit summary right at the top that says, you know, click on your clinical notes to read your provider's progress note. And we've also changed the name of that tab to be a little more obvious to patients what that note tab is.
So we've relabeled it clinical notes instead of just notes, because we also felt that notes was a little ambiguous. And this is the terminology that we came up with, and we've been pretty successful in getting there. And I have one more slide here that I wanted to talk about some of our change management. So we had this initial process where we tested the concept with our providers. We engaged them in what were they worried about. We brought them the data from John's studies, the things he's published about this, and we tried to use that measure of what's the right thing to do for our patients. We think of ourselves as being innovative, and we also use that, you know, well, we're an innovative organization, we do what's right for patients, so this is something we should do. And I think I give credit really to the provider team for being brave enough to jump off another cliff with a new process and try this out, and it has really been fine. We had an undiscernible rate of chart correction requests. And I, as our kind of CMIO role, I have only seen occasional comments from patients that they weren't happy with something in their chart note, really surprisingly tiny number. And most of them, I think, were really places where docs had kind of cut corners in terms of writing professional notes. And what I have tried to say to the doctors that are our providers is, remember, your patients have access to the chart already. This isn't a change. This just makes it easier for them, but they have had for, 40 years maybe, the ability to get copies of their chart notes. So this is not really a change. You should be writing notes that you are proud of in any setting. And then as we onboard new providers, we talk to them about the fact that we have OpenNotes, and this is an example of how we are patient-centered, how we make decisions with new processes by engaging providers, evaluating the concerns, and so on. And I have to say our new providers generally seem pretty enthusiastic about this. I have not had any horrified providers, at least not that said so to me. And they understand that this is part of trying to build a more collaborative relationship with our patients, so that they understand what's going on and can participate in their care. So that's our story. I'm happy to take any questions at whatever point in here that you want to address that.
Thanks, Marcia.
Thanks, Marcia. I think we'll have questions at the end. So, Kerry Litman, who is a partner emeritus at Kaiser Permanente, and I are going to do a role play. We have found this to be effective in communicating kind of all the emotion around the anxiety that clinicians have. In order to do this, we're going to intentionally set up our two characters. I'm going to be the OpenNotes skeptic, the bad guy, if you will. Kerry is the good guy. And now let me just make sure you know that Kerry really is a good guy. He played a major role in getting OpenNotes implemented at Kaiser Southern California, and has really been a champion of patient and family advisory committees. So he is a terrific guy. Now, having said that, let's start. Next slide. So, Kerry, I see millions being spent on the electronic health record, and now OpenNotes is added to it. This is just going to cost us so much money.
John, this is Kate. Do you want me to jump in while we wait for Kerry to figure out his technical glitch?
Sure. Go ahead.
Okay. Well, John, what we can say about the cost is that the technical costs are relatively small. Most EHR vendors already offer this most of the major vendors already offer this functionality, so it's just a matter of flipping that switch. There is some cost related to sort of the political capital you need to use as you're rolling it out and talking to your clinicians. And if you want to put together materials for patients and providers, there is some cost, but it's compared to other interventions in the healthcare system, OpenNotes is a low-cost intervention.
And can you hear me now, John?
We've got Kerry. Okay,
I will cede my time to Dr. Litman.
Well, so Kerry, we're on the second issue here, and I just want to tell you, I'm working too hard already. And it looks like this OpenNotes thing, I'm going to have to work even harder, have more messages, phone calls, and complaints. I'm just too busy for this. Yeah.
So, John, while clinician burnout is a real issue, our research and reports from over 160 other implementers show that, in fact, email volume does not increase. Visits are not longer. Phone calls also show no change. About 15 to 20% of clinicians do need to spend some time making small changes to their notes to create more patient-friendly documentation, as Naomi mentioned. But even when they don't, there have been no big problems. The most common description of an OpenNotes implementation is, as you said, a non-event.
Well, I've got lots of specialty friends, Kerry, and I don't think they're going to like this. I mean, the oncologists, the urologists, the ear, nose, and throat surgeons, I don't think they're going to like this.
Well, again, our research shows that patients receiving care, regardless of their specialty, experience the same benefits and desire access to their notes as much as patients getting care in other specialties. Mental health clinicians are more anxious, but the data for benefits is similar. Adolescent care physicians are anxious, and sharing notes with adolescents can be tricky because there are local regulations that can affect that. But many organizations have succeeded here too. There's no consistent specialty pattern. We know of OpenNotes champions who've seen a benefit of sharing notes in every specialty.
Well, that's reassuring, but some of our physicians, our clinicians, are poor documenters, and it's going to be embarrassing for them, for a patient to read those notes.
Well, it is true that in most organizations, 15 to 20% of clinicians write notes that are suboptimal and should make changes to their documentation approach to make them more patient-friendly. These changes are simple and easily implemented. For example, reducing unclear acronyms and pejoratives, using plain language when possible, and minimizing that dreaded copy and paste. Not surprisingly, these changes can also make the notes better for colleagues. Overall, we've been pleased to see that patients often learn a lot from notes, even ones that many of us think could be better. For most patients, it seems that something is better than nothing when it comes to viewing their clinician's notes.
Well, maybe you're right about that, but I'm skeptical. I think there's a lot of people who can't possibly understand the notes.
Well, given clinicians' many years of training and special expertise, this might on its face seem to be true. But in fact, 85 to 90% of patients report they can read and understand most or all of a note. Less than 10% report confusion. And thinking about it, confusion frequently leads to knowledge. We think confusion is preferable to ignorance, and that giving patients more information improves care.
Well, you're making a case, but I still feel like this is a bad idea. Why are we doing it?
Well, John, have you looked around us lately? The world is changing, and medicine needs to keep up, or it risks becoming irrelevant. Studies show that 99% of patients think OpenNotes is a good idea. They see the benefits and want the option of easy access to their notes. Think about what a clinician would want if they or a family member were ill. They would usually want to see their own or their family member's notes. Fair is fair.
Well, you're right about that, but I could get sued here. I think this could just be easy information in terms of me getting a malpractice suit. I mean, give me a break.
Well, actually, we think it's more likely it will prevent or correct errors that could lead to bad outcomes, confusion, and the dreaded malpractice. A small but significant number of patients do see errors and ask for corrections, and they tend to trust the physicians that make these changes even more. So after 3 years of OpenNotes implementation at Beth Israel Deaconess, there was not any increase in malpractice cases, and I think that's been true as the general case throughout all the 170 or so practices that have implemented.
Well, I got to admit that's convincing, reassuring. But now I do have some colleagues that I think upcode, and when patients see that, they're not going to be happy, Kerry.
Well, no one's actually studied the idea of whether notes can be a way to decrease upcoding or inappropriate notes. If a clinician was performing upcoding, that's going to be noticed by their patients. And if clinicians have any sense, they won't do it. It's one outcome to be afraid of if you're not being honest. OpenNotes may be indirectly helping physicians avoid serious regulatory jeopardy.
Well, that was helpful. I'm going to have more of an open mind on this. Thanks. Thank you, Kerry, and thanks for that role play. So let
You're
me
welcome.
close.
And John, I know you're not really a bad guy. That was very difficult for you to ask those questions. So great job.
Thanks a lot. So let me briefly finish up here and tell you what's next. Next slide. We are going to be distributing the white paper on effective implementations to all implementers and other interested parties. We feel free to circulate it. We hope this stirs a productive and constructive conversation. We are working on effective implementation measurement, and I think that's the key thing. As you all know, you can't improve what you don't measure, and the first thing you have to do is arrive at a measurement that goes across vendors and organizations, et cetera, and we're especially interested in doing so with folks who have Cerner and with Cerner itself. We are working with other outside organizations that are interested in this topic, and there's several. And we'll be following up with implementers to identify their best strategy. I want to mention especially that Epic is presenting a national webinar for Epic customers on this topic. A date hasn't been set, but if you email Deb Wackenheim, we will get an invitation to you. This is, again, for Epic customers. Next slide. So this is what I hope you take home. Just a nice and wonderful and pretty illustration, thanks to our folks at the OpenNotes team. Easier portal navigation plus patient communication looks like it results in higher note opening rates, and this is the start of really improving the effectiveness of implementations. Thanks to all of you, and now I'll turn it over to Kate for questions.
Thanks, John. I've been scrolling through the chat box. There's been a really terrific, spirited conversation going on in the chat box, and most of the questions that have been raised in the box have been answered. There were a couple that I want to be sure just to address. So one, we had a question about how often clinicians at the BI are recording their clinic visits. Those recordings are then transcribed and put into our EHR's notes. And as far as I know, it's not happening all that frequently. We have one very sort of tech-savvy and forward-thinking clinician who uses a microphone that sort of looks like a little robot, and that seems he's very positive about it. But as far as I know, that's not a widespread practice here. And the second question is whether we have guidance on how to help patients resolve when they find an error in their notes. And I will say that has been a difficult problem in that every organization does it differently. There's also state law that varies around the process that organizations have to make available to patients to change notes, and because the record is a legal document, we don't have guidance about that. What we say is that opening notes to patients will mean that patients will tell you when there are mistakes in their notes or in their record, and organizations should anticipate that and should have a process for helping patients for sort of adjudicating those claims. So those were the two specific questions that came in from the chat box. So now let's open it up for general questions.
Hey, Kate, this is Liz Spalding. I saw in the chat box somebody mentioned something about behavioral health. They were asking about at what point do you open the notes for mental health, behavioral health. Maybe there's a quick answer to that.
So one of the things that we see is that organizations will carve out the mental health notes and not open them, and it seems to be a way to help with easing some of the anxiety that John and that John and Kerry and everyone were talking about today. We don't really have guidance on when you should open mental health notes. We encourage organizations to do it. There is data coming out of places like the VA that suggests that patients who have mental health notes, they derive benefits from reading them the same way that patients derive benefits from reading their primary care notes. So based on that, we do encourage places to do it, but we have seen lower uptake of that. We here at the BI, the psychiatry, all outpatient psychiatry notes are shared, and then we have about half of our most of the therapy here is done by social workers, and about half of the social workers are sharing their therapy notes with patients, and what they're finding is that the notes become another sort of therapeutic tool in the toolbox for understanding. It's meaningful for the clinician to see how the patient is interacting with the note, and the patients seem to really like having kind of a reminder about what they talked about or what their homework was before the next session.
Hey, Kate, this is John. I think I would just add that we have some data that suggests mental health patients want to see their notes just as badly as physical health patients, and that they're just as capable of sorting things out and interacting around them, and that the benefits are the same. That has been the VA's experience, for example, that opened mental health notes many years ago, and all of their notes. And so, it's become a personal issue for me to really urge folks. I can see delaying when the mental health clinicians are especially anxious, but give them an opt-in, encourage them to use it, and eventually let's not have a gap between mental health and physical health when it comes to health information.
We just have a few minutes left, and Kate, there was another question in the chat box about how long does a typical implementation take for OpenNotes? Is there a non-production and production feed interface?
So the typical implementation, I think I'm going to turn that over to John because he really is the guru of implementation. From my look in, it looks like it can be very quick. Like Kaiser Northwest said today, we are on this date we are turning it on, and everyone's going to be in the intervention. Other places take a very long time, and John, you can probably talk more knowledgeably about that than I can.
Yeah. Well, first of all, if you're talking about how long does it take to flip the switches, we're talking hours, a few hours of IT time. On Epic, I think on Cerner, I'm not sure about Allscripts or Meditech, but the technical time to do this is tiny. The internal technical time is a little bit more than that, a few more hours, maybe a day or two, but we've been reassured by many internal technical folks that, this is not going to make a huge dent in the internal IT budget to turn OpenNotes on. The big issue requiring time is that political capital around the management of that anxiety, which Marcia did a good job of summarizing, and that's the big variable. And we have seen, as Kate mentioned, Kaiser Northwest took this on, and within 3 months, and a lot of effort, had overcome that political capital situation. A big variable in this is get patients in the room where those discussions are occurring with anxious clinicians. Because patients can do a good job of reassuring them, looking them in the eyes. This is something important to us. Trust us. Your worries are not going to come into play. We have seen some people take a couple of years to go from a pilot to an implementation, and it's all around change management and anxiety management. Now we'll see how we do in terms of moving people, how long it takes to get them to move to more effective implementations. I just might give a kudo to Epic. I think in the last 18 months they have really figured out how to get going on this, and in future versions of Epic, we're really going to see significant optimization, measurement, et cetera, and I hope other vendors will do the same.
Well, it looks like we are at the top of the hour. If we did not get to your question, I've seen over the last minute or so several questions come in on the chat box. If we did not get to your question, please feel free to shoot us an email. We'll happily answer. I want to thank everyone for joining us today, and please be on the lookout. We'll send out a note with information about when the slides are available and the recording. So thanks again, and have a good afternoon.